Now, what do we do? What do we do about suicidality? How do we treat? What do we begin to do? So I'm not going to tell you all about like committing someone or holding them against their will or any of that stuff tonight. But let's just assume for an example case that the person comes in to see the psychiatrist. Okay, the first thing that happens is the psychiatrist has to take a very good history and try to figure out what's going on with the person. Are they depressed? Do they have bipolar disorder? Because until they figure out what kind of disorder is causing the suicidality, they won't know how to treat it, how to begin treating it. As you'll see in a minute, there's some things you can do that if you don't have the right diagnosis could actually hurt the person, make the person worse. So you got to know what you're dealing with first. Second thing is psychotherapy. In all cases, if someone's suicidal, you need to have them in psychotherapy. Now, what happens sometimes is they may be so depressed that they can't focus on the psychotherapy. I don't care. Get them in there, get them started, try to get some rapport going with the therapist at the same time that you get some medicine or some other treatment going, okay? It's much better to be on the medicine and the psychotherapy because, in my opinion, the more angles that you attack a problem from, the more likely you are to fix that problem or to have a better chance of getting that problem resolved. If you just try one thing and not the other, it's not great. It's like having diabetes. And what's the best way to deal with diabetes? It's not just to eat whatever you want and take your insulin. That's not what you do. You watch what you eat, you take your insulin, you exercise, you do all the things you should do, and that's a person who lives a good, normal, healthy life with diabetes. No different with the brain. Okay, so the psychotherapy's going. Now you have to decide what kind of medicine to use. The psychiatrist does that, I guess, not you guys, but I'll tell you a little bit about what goes through the psychiatrist's mind, okay? First of all, are there any FDA-approved medicines for suicide? So he has to think to himself, is there something I can give this patient that's proven to help prevent suicide? The only medicine like that from the FDA that they've approved is for patients with schizophrenia, and it's a medicine that's excellent. It's excellent in how well it works. It's called Clozaril or clozapine. Very good medicine as far as how well it works. It unfortunately has quite a few side effects and other things. So, and it's only been studied to prevent suicide in folks that have schizophrenia. So it wouldn't be something you would use in somebody with plain depression, okay, or bipolar disorder. You would try something else first. Now, what about bipolar disorder? There is some data, some pretty good data, looking at bipolar disorder and folks that take lithium, and they found that folks that take lithium have a lower risk of dying by suicide than those that don't. So lithium, it's not FDA approved now, but there is some good data behind that. With bipolar disorder, and I've talked about this in here before, but you wouldn't want to give somebody bipolar disorder. You remember what that is, right? That's where they have mood swings. They get real high in their mood, sort of like they're on speed. It's called mania. And then they get depressed, very, very low. And we've talked about depression before. Most folks know the symptoms of that. So they swing like that, okay? You don't want to give somebody like that an antidepressant alone. Because what will it do? It might, if they're down here and they're depressed, and you give them an antidepressant, the data shows that they would either go right into mania, or they might bounce around kind of into a mixed state where they have symptoms of both and then bounce up and down more often than they would have otherwise. So the antidepressant will probably make them worse if it's given by itself. If they're already on lithium or they're already on some other Depakote or something else, some other mood stabilizing medicine, then you can sometimes use an antidepressant. Although I think psychiatrists are now starting to lean towards using that later on, after some other stuff that has worked or has been tried. Now, what about antidepressants for plain depression? Here's where it gets, you think it'd be obvious, right? For a long time, we've used antidepressants since the 50s, for plain depression. I'm talking about major depression, clinical depression. And most all of us in the field, myself included, feel that these medicines are absolutely necessary if somebody's suicidal. You either do that or you do ECT. And the only time I would do ECT right off the bat, that's electroconvulsive therapy, is if I didn't have time for the medicine to work. They were that sick and they were that set on dying, and I didn't have time for the medicine to work. ECT would be the treatment because it's gold standard for treatment for depression. It works very, very well. But the antidepressants, there has been some recent publicity about these, okay? And I guess recent, I mean in the last few years. The FDA had put together all the studies from, and bear with me with this, I'm going to give you the story, but it may be that I just have to sum it up at the end and give you the nuts and the sort of the short version, because it gets kind of confusing. But the question was, is there a higher risk when you first start an antidepressant in the first few weeks of suicidal thoughts or behaviors or completed suicide or any of this stuff? So the FDA says to all the drug companies, send us all the antidepressant studies that you have, where you looked at kids first, and then adults with depression, plain depression, clinical depression, and you've compared your drug to sugar pills, placebo. Okay, and let's look and see, is there a higher risk of suicide in the placebo group, the sugar pill group, or the drug group? Okay, what they found was that with the adolescents, the kids and adolescents, there was a 4% risk of suicidal ideation and behaviors. Again, these are, when I say behaviors, these are self-injurious behaviors. This is all that stuff mixed together. So it's not clear what the intent was, but these are kids who may have tried to hurt themselves, carve on themselves, whatever. And so there was a 4% risk on the drug of the folks taking antidepressant, the kids, and a 2% risk in the placebo. So it's a small risk, but it's still there. It's twice what it was for placebo. So the FDA said, we're a little worried if we put some language in the PDR about this and warn doctors and patients and families about it. We're a little worried that people are going to stop using antidepressants, but we still think we should do that because there looks like there's a little bit of a risk. So what they did was they said, you should weigh the risks and benefits before you use these in kids. Okay? We should do that with anybody. We should always do that, right? So if they're very depressed, and the other thing is, you should monitor these kids very closely when you start the medicine, because it's usually in the beginning that there's going to be an issue. So you monitor them very closely, and the things you look for are signs that might signal you to them getting more risk for suicidal stuff. The anger, the mood changes, the anxiety, the sort of agitated type stuff. Okay, so they take the antidepressant and they're depressed, and now they're kind of agitated. They're not sleeping. They're just restless. They can't, they're agitated looking. Okay, those are the ones that probably are higher risk for something, for having a suicidal ideation or something else. Now remember, I said 4% and 2%. There were no completed suicides in any of those patients. Okay, thousands of patients, no completed suicides. So it's not showing that there's a higher risk when you start the antidepressant that more people are going to die. That's not what it's showing. It's showing more people might have thoughts of hurting themselves or carving on themselves or something like that, but not death. Okay. The thing you've got to keep in mind is that the risk of death from untreated depression, remember what I said it was? 15%. Okay, that's high. That's much higher than using the antidepressants. Okay, so now that's a kid's story. Okay, now this year, and actually just December 13th, the FDA had put together. They looked at all the adults. They looked at all the same stuff, but this time they looked at adults instead of kids. Okay. And again, what they found was less than age 25, it looks like there may be a higher risk of that there's a higher risk than sugar pill of the suicidal ideations and behaviors. Again, not completed suicide, okay, but the behaviors, less than 25 years of age. Between 25 and 30, it was equal between sugar pill and drug. Over the age of 30, the antidepressants were protective. There were less problems with suicidality than there were in the placebo group. When they got above 65, extremely protective. As a matter of fact, if you're not using an antidepressant in that age group for treating depression, you're not practicing standard of care if you don't use them. So I think the key is really in any age group you need to monitor your patients, but especially those less than 25. Now, why is that? Is there something inherent with the antidepressants that are making these folks worse? Nobody knows. The FDA didn't know, and they actually called an advisory committee of experts that are, not drug company folks, but these are unbiased people, experts in the field, to figure it out. And nobody's absolutely sure. There are a lot of theories being proposed, and I think two of which make the two that make the most sense to me are, one, that if you think about a person less than 25, their brain may not be fully wired the way it should be yet. Okay? We know that in adolescence, their brains are changing dramatically. They're getting pruned. The brain is getting pruned quite a bit. And it could be that there's some pathway or some pruning going on that is putting these folks at higher risk for suicidal thoughts and things when they take the antidepressants. Maybe it's as simple as impulsivity, right? How many adolescents are impulsive? A lot, right? I mean, none of them think really about the consequences of what they do before they do it. They just do it. And then, and so that part of the brain, whatever makes them impulsive like that, might make them more likely to, try to hurt themselves or do something like that. So that's one theory. The other theory is, these are young people. What if they're bipolar, but all you're seeing is the depression? So they're so young that the only episode, you don't see the mania, you don't see the highs. All you're seeing is the low. Well, you don't have any other way of knowing if they're bipolar disorder. I mean, usually when I take a history, I'll ask one of you guys, have you ever had times where you've been really high, where somebody said you look like you're on speed, or a soccer mom on meth, or something like that, and they, they'll say yes or no, and sometimes you have to ask the family, because people themselves, they like feeling like that, so that's no problem to them. But anyway, with a kid, it's hard because they haven't lived long enough maybe to have an episode of mania. And so you're treating the depression, you start them on an antidepressant, and you make them worse, like I just said. You don't want to use an antidepressant alone in a person with bipolar disorder. So maybe some of these kids are actually bipolar, but we're not able to pick that up. Our diagnosis is not, all we can do is ask symptoms. We don't have blood tests and brain scans and all that stuff to do. So that makes it very difficult, and I think that those things could be what's going on, and that could explain why the younger population is more at risk than the older population. But in general, not treating depression is way worse than treating depression. And so I guess that's sort of the take-home message. And then finally, I'm all done here, but I wanted to show a couple of things. One is a couple of suicide hotlines, if anybody's interested. And I don't know if you can focus in on that. It's probably not going to show up real well from a distance, but these are suicide hotlines that, of course, if people have family members that are in a crisis situation, or hopefully maybe not so crisis, but enough that they have time, they can call somebody and talk to them about what to do and that kind of thing. That's what these are. And I can read them out, I guess. The first one is 1-800-273-TALK, which is 8255, and then the bottom one, this may be even easier to remember, is 1-800-SUICIDE. And that number is 1-800-784-2433. So those could be helpful to someone at some point. I'll turn this when you're done copying here. All done? Okay. And then finally, I put up a couple of websites. The first one is the American Association for Suicidality, and it's www.suicidology.org. Let me make sure I got that. That's right. And then the National Institute of Mental Health, and it's www.nimh.nih.gov. And it has lots of links. And actually, this is a good one for about any kind of brain illness, psychiatric illness that you're interested in. There's a lot of information there about all these different things, but suicide included. So, now, does anyone have any questions? That's a lot of talking there. No questions. All right. Well, yeah.
I have one, David.
Yeah.
What creates a mind that would go suicidal like these terrorists did?
Well, that's a good question. I've never interviewed somebody that went through something like that. I don't have any personal experience at all with it. Near as I can tell, this is totally without seeing any of them, but I think that they don't view it as, I don't want to live anymore. It's not like they're depressed and they're saying, I don't want to live anymore and everybody'd be better off without me. It doesn't sound like that's what's happening. I think what's happening is from just watching the news and all. So it's it's not a very good professional opinion. But I think that they've been told and taught as part of their, I don't know if culture is the right word, but especially maybe religion, that the folks that they are going to kill are the enemy, and that they will go to heaven if they like the more people they take out of the enemy, the better off they'll be, and the more rewards there'll be in heaven for them. So they look at it as like a way to get to heaven, I guess. Here in our culture, we tend to think, you have to be, well, if you're Christian, you to be saved, so to speak, to go to heaven. So but to be saved, you have to be a good person. You have to watch out for your common man, put them before yourself, and so on. I think this is just a completely different religion and belief system that they have, and they've been raised in that or taught that from very early on. A lot of these are younger people, and they fully, wholeheartedly believe it. And I don't think it's not something I think you can treat, so to speak. Unlike what we're talking about here, where we're talking about depression and things that are very treatable. That's not something you can treat necessarily. I think that would take changing their whole faith system, and you wouldn't be able to do that probably unless I don't know how you do that. So that's my guess. I mean, that's not no educated guess really. That's more of a from what I've seen and read. But yeah.
I've heard you speak before, and it seems like regardless of the subject, that when it deals with issues such as bipolar or suicide, whatever, you're associated with serotonin. So do all of these, I'm sure not all, but do a lot of these medications, is it trying to adjust the serotonin in the brain? Or?
Yeah, many of the medicines do. The antidepressants in general, they're very commonly used. And so I'll tell you my opinion on this. Serotonin it's kind of a common or populous chemical in the brain, neurotransmitter is what it's called. But there are a whole bunch of other neurotransmitters. And we're starting to learn now that, these medicines boost serotonin in certain parts of the brain, and we think that that's how they work, right? Well, it's more complicated than that. It's just that's an easy way to put it, And I think, as the field evolves and science evolves, we start to learn more and more. To give you an example, I mentioned that they don't work very quickly. So it can take an antidepressant. I mean, sometimes 10, 12 weeks for full effect. Well, you might ask the question, well, how come it takes so long to increase the serotonin? It doesn't. It takes 2 to 3 days. Within 2 to 3 days of starting a serotonin medicine, the serotonin in the brain, the levels of the serotonin in the brain go up. So if it was just increasing serotonin, how come it takes 10 to 12 weeks to work? It's probably not that simple. Probably what happens is we think now that the serotonin goes up, which is good, and that's necessary. That in some people that has to happen. Incidentally, not everyone who's depressed it's not always because of low serotonin. It can be other things. It can be norepinephrine, dopamine. There's some other chemicals that we think are involved. And it may not even be the chemicals at all. It may be that whatever's causing the depression happens to also cause the chemicals to be low. But in any case, you take the medicine, it boosts the chemicals kind of quickly, and then as time goes on, there's probably a cascade of other things that happen. So you boost up the serotonin, and that causes something else to happen in the brain, which causes something else in this and that and the other. And that whole process, maybe that whole process is what takes 10 to 12 weeks, for full effect. Does that make sense? So we put it simply sometimes because our own brains have a hard time conceptualizing, but also the science isn't fully there yet. So, good question, though.
What are some of the medications for serotonin?
The antidepressants that work on serotonin. They're called SSRIs as a class. You always think of medicines as a class, and then what are those medicines in that class? I don't like to mention brand names much in here, but I will to answer your question. But Prozac was the first one out, and then there's Luvox. These are brand names, but there's generics now. So generic for Prozac is fluoxetine. Luvox, the generic is fluvoxamine. Celexa is another one, and Lexapro is another one. Zoloft and Paxil, those are all serotonin medicines. I'm trying to think if I missed any. I don't think so. I think I got most of those. And then there are other medicines that work on serotonin too, but also work on another chemical called norepinephrine. And that's like Effexor and Cymbalta. Those are the only two of those that are around. There are some older antidepressants that work either just on norepinephrine or a little bit on serotonin and norepinephrine. And they've been around for years, but things like imipramine and Pamelor, those are brand names again. But all of these are generic. I mean, they come generically now. But the brand names Pamelor, Imipramine, trying to think of Doxepin's another one. So amitriptyline, well, that's a generic. Let's see, that was Elavil. Amitriptyline is Elavil. So a lot of chemical names. Apologize. But there are a lot of antidepressants that are out there. So, and medications in general. Each of them is a little bit different. So some people ask the question, if I take one of those, let's say I take Prozac, and it doesn't work for me, or if I have side effects or something, does that mean that another one in the same class is going to have the same problems? And the answer is no. I mean, you may tolerate it, and it may work just fine for you. So maybe Prozac doesn't work, but Celexa does, or any number of combinations. So not one medicine works for everyone. But in general, they're all equally effective. So if you take 1,000 patients and you study them, versus placebo, the drugs work about the same rate. So, if that makes sense. Okay. Any other questions? All right.
What is the percentage of the population that's treated for clinical depression?
That's a good question. In our society, I think it's 70 million people that have depression in this country. But I don't think that's all treated. That's probably not all treated. I don't know what the number is that's treated. Not sure how we'd get to that, I guess. How we'd know that number, I don't know. But
it
then
just
again,
seems like it's growing exponentially.
oh, it certainly is growing, yes, absolutely. When this new class of medicines, the SSRIs, came out, the older ones I mentioned, the amitriptyline and imipramine, they had some side effects, and some side effects that bothered people, more, and so people wouldn't take them as often. These new ones came out, and they're people felt like they're much safer, although safety is kind of a question. In any one patient, you can have certain side effects, and if you don't like those side effects, you're not going to take it, right? So the new ones have those things too, where patients will say, I don't like this feeling or that feeling, and I'm not going to take this medicine. But by and large, the new ones seem to be a little better tolerated than the older ones, and doctors were much more comfortable using them, especially family practice and internal medicine doctors, primary care doctors. So I think the antidepressants have gotten much more widely used, and not to downplay at all some of the marketing and other things that has gone on, with pharmaceutical companies and all. So, that's all those things are behind the use, but still, depression is far underdiagnosed and undertreated. It still is, even though we've had a big increase in the treatment of it. And I tell you, what's fascinating to me is how hard it is to tell sometimes. You can have a patient come in and they won't even know that they're depressed. And you can't figure out that they're depressed. I had this happen to me. A gentleman came in, and I can't remember what his complaint was, maybe some kind of anxiety. He didn't identify any depression. I asked him all the depression symptoms. No. And, he denied all of this stuff. Of course, again, no brain scans, no blood tests. I couldn't tell for sure. His wife comes in 2 or 3 sessions later. He wasn't getting any better, and I couldn't figure out what was going on. His wife comes in. She says, he's depressed, don't you? I'm like, no, I didn't know he was depressed. Thank you for coming and telling me that. So we got him on the right treatment, and within 10 weeks or so, the guy was good as new, and he felt better than he had in years. So I tell you, it's difficult. Depression sneaks up on you. It's not. You don't wake up one day and all of a sudden you're depressed, and boom, it's clear as a bell to you that you're depressed. It sneaks up on you, and it's subtle. It can make you just irritable, make you look at the world sort of negatively. Everything's kind of grumpy around you. Nothing's good in your life. And it sneaks up on you, and it sometimes takes a family member or somebody else to say, 6 months ago you just didn't seem like this. Something's wrong, and that's usually how it's identified. It's sometimes people come in on their own because they're suffering, they feel it so much, but other folks just have no clue and don't it just sneaks up on them. So.